we can use a lower dosage. There are some medications where the dosage is far higher than what is actually necessary. And we can see that if we use the lower dosage, we can maintain the same health outcomes, sometimes reduce the side effects, the toxicity of the medication, and also massively reduce the expenditure as well. The same with less frequent dosing. Sometimes a medication is given every 3 weeks, but you understand the pharmacology and the medicine and everything, and you realize that actually you can probably give this medication every 5 weeks instead of every 3 weeks, and that'll reduce toxicity and reduce cost as well. And then you can also give for shorter duration. There may be a medicine that you give for a year, but actually it may work just as well if you give it for 6 months instead of a year. So we started evaluating and looking at all different approaches here. And this is one example, abiraterone or Zytiga in prostate cancer, which we normally give the labeled dose from the trials and on the FDA approval is to take 1,000 milligrams, but on an empty stomach without food. But we know that if you eat together with this medication, eat a meal, then the absorption of the medication is higher. And they did this study and showed that you'll get the same effect if you take a quarter of the dosage, but with a meal. Okay, nice, right? Here's another one, zoledronic acid for cancers that are in the bones, for protecting the bones. It's labeled to be given every 4 weeks, but there was a trial done here showing that if you give this medication every 12 weeks instead of every 4 weeks, you'll have the same effect from the medication. Here's trastuzumab or Herceptin that's given for HER2-positive breast cancer. Originally, it was considered that you have to give a whole year of treatment in this setting, but it was thought, well, hold on a minute, maybe 6 months can have just the same effect. So they did research trials and a lot of research, both in England and in France, and they compared giving 6 months versus 12 months. And they showed that there really is no difference between giving 6 months versus 12 months. You can get into some statistical debates, etc., but there's really no significant clinical difference if you give 6 months instead of 12 months. And obviously, that's half the cost, right? Now, this is one of the main things that I've worked on for several years is pembrolizumab, which is Keytruda, which is a main immunotherapy with a huge expenditure around the world. And it was initially given at 2 milligrams per kilogram, but then essentially most people now give it at 200 milligrams every 3 weeks. But we established and we showed the fact that you can actually give a lower dosage. You can definitely give 25% less dosage instead of using what's called weight-based dosing instead of fixed dosing. That's minor details, don't need to get into it. But you can reduce the dosage definitely by 25%, have the same health outcomes, and save a tremendous amount of resources. And so as a result we published the first paper on this work, and a lot of the world then started being very interested in it and looking into different ways, and they've adopted it in many countries now, in Canada, Denmark, partially we did it in Israel, in Iceland, the Netherlands, in Kaiser Permanente in the USA. And there's many other drugs where there's opportunities for reducing the dosage and maintaining the same health outcomes. These are the CDK4/6 inhibitors, which is abemaciclib and ribociclib and palbociclib for breast cancer. Sometimes if you give a drug, when the patient has metastatic disease, if you give a drug first line or second line, we don't always know which is better. But if you give it first line, it takes the duration of treatment is a lot longer. And so in Holland, they've been starting to look into lots of different new concepts of looking at more cost-effective approaches. And here they showed that with these medications, if you give it in second-line treatment instead of first-line treatment, it has the same health outcome. It has less toxicity, less side effects because of a shorter duration of treatment, and less cost as well. So it's good for the patient because less side effects, and it's good for the healthcare system because of less cost as well. One of the final things I just want to talk about as well is class effects in oncology, is that in many medications, historically, if we talk about ACE inhibitors or proton pump inhibitors, all of the old medicines that we use for in general internal medicine. If we look at the, it's generally accepted that many of these medicines are the same, and the insurance companies often will do a tendering process and go to the manufacturer and say, who's going to give us the cheapest price? And whoever gives the cheapest price, you then do a preferential listing on the formulary, and only the cheaper one is available. But this hasn't generally been done in oncology because people were too concerned. It's cancer. We're not sure we want to mess with it. It's cancer, and the clinical trials are a little bit more complicated to understand, and so it hasn't generally been approached. But I'm now trying to push forward and trying to say, look, there's many medications in oncology where they're very similar. For example, nivolumab and pembrolizumab, or Opdivo and Keytruda. They're really very similar. They do the same thing. Here's the example of the androgen receptor blockers in prostate cancer, and we can see that the effect size, they really have a very same effect. And so there's opportunities here for to do a tendering process, to go to the manufacturer and say, these drugs are the same, who's giving us your cheapest price? And then whichever one gives the cheapest price, that's the preferred medication. And this can cause, anecdotally, it can cause 30% price reductions, etc., with this type of a negotiating tool. And that's all I have to say. But I just want to really thank the leadership at A.C.Camargo, the researchers, the clinicians. They're doing an amazing job with really treating patients and designing, trying to give medical care in a principled and honest and decent way, and at the same time trying to look for ways to tackle this huge challenge, which is already upon us and is only going to get harder and harder. So thank you very much.